Here I'll be covering about EOG, electrooculography, and visually evoked potential. So first, before talking about electrooculography, we need to know what is standing or resting potential. So in a normal eye, there is a flow of electric current between the front and the back of the eye as the cornea is positive with respect to the back of the eye. And the difference in electric potential between the anterior and posterior part of the eye is called as the standing or resting potential. So the EOG is basically an indirect measure of the amplitude of the standing potential, which changes in both light and dark adapted states. So EOG, which is electrooculography, is an electrophysiological test which tests the outer retina and the RP and basically determines the function of the outer retina and RP. So how do we perform an electrooculography first? So the patient needs to be in a dilated state, and we have active and ground electrodes, so which are made of silver, and gold cup electrodes. And you have a Gansfield dome, which has uniform illumination of about 100 candela per meter square, with two fixation points as shown in the picture, about 15 degree to the right and left of the center of the eye. So the active electrode is placed on the medial and lateral canthus of the eye, and the ground electrode is placed on the forehead. The saccades, the light and dark phase are then recorded. So what are the primary components of an electrooculography? So first is the saccades. The saccades are usually recorded in the first 10 seconds of each minute, and as shown in the Gansfield dome, those two fixation points on either side of the, about 50 degrees from either side of the center of the eye, usually stimulates these saccades. And both light and dark phases, saccades are recorded. So then comes the dark phase, which is lasting for about 15 minutes. And in the dark phase, you will see progressively decreasing amplitudes. The least amplitude or the lowest amplitude is known as the dark trough. It occurs at about 8 to 12 minutes. And then comes the light phase, which lasts for about 15 minutes, where you see a progressively increasing amplitudes. And the max amplitude during the light phase is called as the light peak, and it occurs at about 6 to 9 minutes. The next component is something called as the ardence ratio. So what is an ardence ratio? It is nothing but light peak divided by dark trough. So normal ardence ratio is about greater than 1.85, and subnormal is between 1.6585, and anything below 1.65 is significantly subnormal. So when looking at an electrooculography report, there are three main components which we need to read before interpreting the report. So first, we need to look at the saccades. So when looking at the saccades, which I've marked as 1, you need to know if all the waveforms are present, if there are any artifacts, and if all the waves are in a sinusoidal pattern. So if all of this, like I said, is present, then the report is reliable. And the second part, what you look at is the graph, which has the light phase and the dark phase. There you mainly need to identify where the light peak and the dark trough is, their amplitudes, and the time of occurrence. And the third part, which is the most important part, is you need to identify the ardence ratio. So the ardence ratio here, you needn't divide and calculate. It will already given in the report. So in this report, it's already written as the right eye about 3.4 and the left eye about 3.007. So more than these three components, among all these three components, the third part, which is the ardence ratio, which will already be printed on the report, is the most important. So if you identify the ardence ratio, and if you know what is the normal ardence ratio, then you will know if the electrooculography is normal or abnormal. So coming to the clinical applications, so usually whatever the indications which ma'am has already told in ERG are the same indications you get for EOG, but only one main disease which EOG is very important is Best disease. So in Best disease, you normally get a normal ERG, but the EOG is abnormal. However, when you have an autosomal recessive Best retinopathy, where the ERG and EOG both are abnormal. So in Best disease is the most useful clinical application you have for EOG. So all other indications have already been covered in ERG, such as Stargardt's disease, retinitis pigmentosa, and other retinal and macular disorders. So this is basically how do we interpret an EOG. So like I told you, this is the EOG. So first I look at the saccades, if they are normal or abnormal. So and then I'll directly go and look at the ardence ratio. So here the ardence ratio, the right eye is 3.4 and left eye is 3.0. So this is a normal EOG. So this is a 32-year-old male who came with complaints of defective vision in both his eyes. Right eye visual acuity was 660 and left eye was 636. The fundus picture is like shown below. So when looking at the electrooculography of this patients, first, when I'm looking at the circuits, all the waveforms are present and it's almost in a sinusoidal pattern. There are not much artifacts. The ardence ratio on the right eye is about 1.4 and the left eye is about 1.44. So it's less than the normal. So the ardence ratio in such case is abnormal. So the EOG report is reliable and the ardence ratio is abnormal and correlating with the clinical picture. And if you also have a full field ERG, you can arrive at a diagnosis of Best disease in such a case. So the next electrophysiological test, which I will be talking about, is visually evoked potential. So VEP is nothing but a record of electrical activity of the brain in response to a flash of light or a pattern stimulus. It mainly checks the integrity of the visual pathway and can diagnose pathologies related to the visual pathway from the optic nerve up to the visual cortex. So what are the common indications why you perform a VEP? Is mainly for disorders of the optic nerve, mainly demyelinating optic nerve diseases, ischemic, toxic, and traumatic optic neuropathies, to rule out malingering, amblyopic cases, unexplained vision loss, to assess visual prognosis prior to any surgery, to assess the visual potential in infants, poor and unresponsive patients. So how do you perform a VEP? So the patient is made to sit about 1 meter from the stimulus presentation, like it could be a Gansfield dome or a monitor in a dimly lit room. So each eye would be tested separately. The pupil should be in an undilated state and refractive error corrected. So then the active electrode is placed on the occipital lobe, the reference electrode is placed in the forehead, and the ground electrode is placed in the earlobe. And there is a monitor or a Gansfield stimulator. So the monitor provides the pattern stimulus, and if you are using a Gansfield stimulator, it provides the flash stimulus, which I'll be talking about later. And the stimuli is then, responses are then amplified by a signal amplifier, and your results are then produced. So depending upon the stimulus used, the VEPs can be classified as a flash VEP, where you use where the stimulus is nothing but a single flash. It subtends at about 20 degrees to the visual field, and the flash occurs at a rate of about 1 per second, and at a candela or illumination of about 3 candela per meter square. And the second type of VEP stimulus would be a pattern stimulus, where it could be presented in an on and off checkerboard pattern or a reversal checkerboard stimulus. So the first is the pattern onset offset VEP, where a checkerboard stimulus is presented in an on and off pattern. So two types of checks are tested in both pattern onset and the next type pattern reversal VEP, where the small and the large checks are usually tested. So in a pattern reversal VEP, again you have a checkerboard stimulus, where the stimulus is presented in a reversal pattern. So why do we check two sizes of checkerboard stimulus is that? So normally the small checks are about 15 minutes of arc and the large checks are about 60 minutes of arc. The small checks are the best stimuli to test the foveal function and the large checks are the best stimuli to test parafoveal function. Therefore, pattern stimulus both either can be a onset offset or the pattern reversal VEP. Both the small checks and the large checks are checked. So the most commonly performed VEP protocol is the pattern reversal VEP. So pattern reversal VEP, like I said, already has a checkerboard pattern which is presented in a reversal or reversal state. So coming to the waveform in a pattern reversal VEP, normally you have two negative waves at about 75 and 135 milliseconds. It's called the N75 and N135, and a positive wave at about 100 milliseconds, which is the P100. So when looking at a pattern VEP report, we need to only be bothered about the P100 waveform. So when looking at the P wave 100, two parameters need to be assessed. First is the amplitude, second is the latency. So how do we calculate the amplitude of P100? It's from the trough of the N75 to the peak of the P100. And how is the latency calculated? It's from the time of application of the stimulus till the peak of the P100. So we needn't actually calculate, it will already be given in the report. So if we know what are the normal values, it will be very easy to interrupt a VEP. It's not very difficult. So what are the normal values with respect to P100? So normal P100 latency is about 90 to 100 milliseconds. And anything over 120 milliseconds, we can consider abnormal. Or when you have an interocular difference about greater than 10 milliseconds, we can consider abnormal. So what is the normal amplitude of a P100? Anything greater than 4 millivolts would be normal. Anything less than that is abnormal. So what are the diseases and where the P100 is affected? So in mainly demyelinating optic nerve diseases, the P100's latency would be prolonged. So what are the diseases in which the amplitude would be reduced? In any optic nerve diseases, like ischemic optic neuropathy, toxic or traumatic optic neuropathy. So in nerve compression, there's optic nerve compressions, both the amplitude and the latency would be affected. So various factors can affect a VEP waveform. So first, the age. So the latency increases by 2.5 milliseconds per decade after the fifth decade. Males have longer latency when compared to females. And in the dominant eye, there's a shorter latency and a larger amplitude. And various drugs can also affect the VEPs, along with uncorrected refractive errors, media opacities, amblyopia, fatigue, and inattention. So coming to the, what are the main clinical uses of a pattern reversal VEP? I've already told you before, is just to rule unexplained vision loss, to rule out malingering, and mainly optic nerve pathologies. So the second protocol is the pattern onset offset VEP. So where you present a checkerboard pattern in an on and off sequence, large and small checks are checked. So most common uses is that mainly it uses in cases of malingering, nystagmus, and an albinism to detect intracranial misrouting. And the third VEP protocol is a flash VEP, where I use a single flash about 2 candela per meter square, subtending about 20 degrees to the visual field, and mainly used to assess the visual function in infants and poor cooperative patients, those who cannot fix, and the presence of dense opaque media to prognosticate visual prognosis during a surgery. For completion's sake, so what is a SWEP VEP? It is nothing but it records the VEP within a few seconds. It's just a faster way of recording a VEP. So it rapidly can be used to assess the visual acuity, mainly in non-verbal children and in malingering patients. And multifocal VEP, which is also not commonly used. So what is a multifocal VEP is that a conventional VEP is nothing, a mass response for the cortical elements of the entire stimulated visual field. But a multifocal VEP mainly records focal cortical responses from multiple sites in the stimulated visual field. And main indications, it is useful in glaucomatous patients for mapping visual field defects and in optic nerve pathologies. This is how a multifocal VEP response would be displayed. So coming to how do you interpret a VEP? So like I told you, clinically, the most commonly used protocol is a pattern reversal VEP. So this is how your VEP report would be, depending on the machine company. So you would have the right eye wave in the right side and the left eye waveform on the left side. So like I told you, P100 is the most important parameter we need to look at. So the most important waveform we need to look at. And in that, we need to assess its amplitude and its latency. So there's a right top hand corner, there would be a box which would be displaying the amplitude of the P100 and the latency of the P100. So in this report, the latency in the right eye is 95 milliseconds, left eye is 97 milliseconds. Amplitude in the right eye is 10.9 millivolt and left eye is 9.7 millivolt. So all of this falls in the normal range. So this is basically a normal VEP report. So this is the next example. So I'll read out the values. So in the right eye, the latency of P100 is about 105 milliseconds. Amplitude is about 9.4. And in the left eye, the latency is about 145 milliseconds and amplitude is about 9.47. So in this, what is abnormal? The amplitudes in both eyes are normal. The latency of the right eye is normal, but in the left eye, it's delayed. So delayed latency in the left eye would be more in favor of demyelinating optic nerve pathologies. So this is the next VEP report. So the right eye and left eye. So right eye's P100 latency is about 97.5 milliseconds and left eye is 96.5. And the amplitude is the right eye is about 2.6 and left eye is 2.2. So in this report, the P100 latencies are normal, but in both eyes, the amplitude of P100 is reduced. So it could be done, we need to correlate clinically and identify what type of optic nerve pathology it is. It could be a toxic, traumatic, or ischemic optic nerve disease. So this is the next case where the amplitude of P100 in the right eye is about 11.06 and left eye is about 5.1. And the P100 latency in the right eye is 142 and left eye is 111. So in this case, there's a reduced amplitude of the left eye, P100, and this is more suggestive of ischemic insult to the left. So this is the last thing. So right eye is P100 latency in this case is about 93.5 and left eye is 113. And in the left eye, the amplitude is about 0, non-recordable, and the right eye is about 0, non-recordable, left eye is about 3.7. So the amplitude in both eyes are affected. So could be any, this is a case of bilateral traumatic optic neuropathy.